I'm Dr. Julie Elner. You're watching Chapter 4 of my bariatric surgery video. We'll pick up where we left off in Chapter 3. We're going to talk on the next slide about how a band works. The band starts by making little tiny incisions, just like all laparoscopic surgery. This is how all laparoscopic surgery looks from the outside. We're going to go in and look at the top part of the stomach and put an inflatable inner tube around the top part of the stomach, basically to pinch the stomach down, kind of like having a tight belt around your waist. So the band is going to go in through one of the external instruments. It's going to wrap just like a belt around, leaving about a golf ball size portion of stomach above the band, which is pinching down. Then we bring the tubing that's attached to that little inner tube temporarily out through one of the incisions, and a little button, which is called a port, is attached to the tubing, and the whole thing is tucked inside. So when you have a band in place that has not been tightened, it pinches a little bit on the top part of the stomach. So when food comes down into the stomach, you fill up that little stomach, and then it hits that little pinched part. And it takes a while for the food to make its way out through that little pinched part, kind of like food is moving out through the bottom of a kitchen funnel. But the neat thing about a band is that we can adjust it. So 4 to 6 weeks after your surgery, you'll come into the office and we put in a little tiny needle that's kind of like a blood drawing needle, only smaller, and squirt in a little bit of saline. And what that saline does is that it tightens down the inner tube, making the pinched part a little bit smaller, as you see in the video here. So basically what we've done is we've made the bottom part of our funnel a little bit tighter. So when food goes in, it actually takes less food to fill up the stomach, and this video actually doesn't show that very well, but what it does demonstrate is that food moves through very slowly and empties out of the stomach very slowly in little tiny bits. So the point of the band is that it offers adjustable portion control. By tightening the band, we decrease the amount of food that people have to eat in order to feel full, and it also prolongs that sense of fullness by making the food kind of hang up in the upper part of the stomach as it slowly moves out through that pinched part. This is Autumn. She's one of my band patients. You can see after surgery here, she's down 137 pounds in 13 months. So some of the advantages of bands. They're the least invasive. There's no internal cutting of the stomach during the surgery. You can qualify at a lesser weight. It's definitely the easiest to reverse if you want it reversed. And the patient is in total control. So I decide with my patients when they come in for their visits whether or not they feel like they need an adjustment in the tightness of their band. Some of the disadvantages: it doesn't decrease that ghrelin like the gastric bypass and the sleeve do. So it provides adjustable portion control, but it doesn't have any of the chemical effects of the other surgeries. It does not decrease your ghrelin, and it does not provide an increase in your metabolism. Some people find that a foreign body is just a little bit unnerving to them. They don't want something from the outside being put in their body, but let's put it into perspective. Anytime you have surgery, you have foreign bodies that have been left inside of you, whether it's a clip or a staple or a suture of some kind, or if you've had orthopedic surgery, you have plates and screws and false hips and false knees. By the time we go to our grave at the end of our life, we're going to have some sort of bits and pieces that some surgeon has left inside of us. So just put that foreign body into perspective. But the weight loss is substantially less than the other operations. It is the least invasive surgery, but it also provides the least help and statistically the least weight loss. So some of the complications. Well, a band can kind of shimmy up and down on the stomach and slip out of place. That's one of the reasons why sometimes people have to have their band removed. I do counsel my patients to eat properly so they decrease their chance of pushing their band out of place. If the band is over-tightened, it can cause what's called an erosion. If a patient goes to a physician who really isn't a bariatric surgeon or isn't really adept at adjusting patients' bands, they might accidentally put too much saline in there and make the band too tight, and it will actually start to rub and chafe and cut through the top part of the stomach, and that's what's called an erosion. That has never happened to one of my patients, but the point is you have to be careful about who you choose to put in your band and manage your band. Don't expect your primary care doctor to do it. You need to follow up with your bariatric surgeon. If your band is made too tight, you might start to vomit or even get a pneumonia, and you'll need to have your band loosened up. The port, which is the little piece under the skin that the needle goes into to make the adjustments, just from scar tissue, it might be pulled sideways underneath the skin. If that happens, it's a pretty easy operation. We just open up the same incision, put the little port back down flat, and you're fixed. But like any foreign body that's in your body for any reason, it could get infected and may have to be taken out. So reoperation may be necessary in some cases, but many complications, and this is true of all the surgeries, many complications are avoidable with good aftercare from a fully trained bariatric surgeon. So let's shift gears a little bit and talk about the gastric bypass. This is still the gold standard weight loss operation in the United States. There hasn't been another operation that can compare favorably in terms of weight loss versus low complication rates. It definitely has the best weight loss of all the operations that are currently available. It has a very low complication rate. We've been doing this since the 1960s, so we do have it fairly well figured out. And actually, statistically, it's safer than getting your gallbladder out. It's a more complex operation internally than the band is, so we'll go through it a little bit step by step, and it does require almost a 48-hour stay in the hospital. The band patients get in and out on the same day, but the return to work for all 3 surgeries is the same. My patients go back to work at about a week. This is Jody. She's one of my patients who came to me just over 10 years ago wanting a gastric bypass, and she was in her mid-20s. She had hypertension, sleep apnea, depression. She was infertile. She was exhausted at the end of the day, and the picture demonstrates how she felt at the end of every day. She worked in a preschool. She would come home completely exhausted and collapse on the couch, and the cat would park itself. And the cat is actually the one in the picture that looks happy in this picture, and Jody does not look happy. But she came to me very fearful of the changes that surgery would bring. But she went ahead with the surgery because she knew that she was going to die if she didn't have bariatric surgery. This is Jody 10 months after her surgery out east of San Diego enjoying the sand dunes. And this is Jody 6 or 7 years after her surgery at the top of Cowles Mountain, which isn't too far from the clinic here in San Diego. And she's basically just keeping active, keeping her weight off, making exercise a part of her daily routine. And her life has changed in just about every conceivable way. But if you ask Jody what the best part of her surgery has been, she'll tell you that she became a mom because she was infertile. She was in a bad relationship that was unhealthy for her as a woman. When she lost weight, she got healthy, she gained self-confidence, she found a wonderful man who treats her like the queen that she is. She has 2 beautiful kids, and she has the life that she would have never been able to live. So in order to understand the gastric bypass, you have to understand a couple of things. When food goes into the stomach, no matter how big or how small the stomach is, you physically feel full. But we oftentimes don't stop eating just because our stomach is physically full, because the food is continuing to taste good. So we'll continue to eat, and food will leave the stomach and make its way into the small intestine. On this picture, the small intestine is that twisty-turny glob of tubes that you see. But when food makes its way down into the small intestine, that's when you get a completely different signal up to your brain, shutting down your brain's desire for food. So when food is in the stomach and fills up the stomach, you get physical fullness, and the brain shuts down its desire for food when it gets into the small intestine. So remember that so you can understand how the gastric bypass works. So the first thing we'll do in a gastric bypass is we'll go to the upper part of the stomach where we talked about putting a band in, but instead of putting a band in, we're going to cut the stomach into 2 pieces with surgical staples. So now we have a tiny little golf ball sized stomach that's going to fill up on a very small amount of food. That's going to give you the sense of physical fullness. But this is where the gastric bypass is special. The next part of the surgery is tracing the old stomach down into the small intestine. So when food hits the small intestine, you're going to get a shutdown of your chemical appetite. So we've just cut that small intestine, and we're going to take that piece of small intestine and bring it up to the new little stomach to catch the food. So you're going to see food coming down in blue clouds. When food goes into the new little stomach, you feel physically full, but the idea with the bypass is that we get the food into that piece of the small intestine, and immediately you get appetite shut down in your brain. Now you see the food, which is blue, making its way downstream into the rest of your digestive tract. But the other thing that you're seeing is that the old stomach is making that yellow stuff. Now the yellow stuff is acid and chemicals that your stomach naturally makes to help you digest food. And we have to mix in the acid and the chemicals with the food that you're eating in order to digest it properly. So your old stomach there is still making the acid and the chemicals completely normally, and it's draining out in yellow, and you're going to see the acid and the chemicals coming down from the old stomach mixing in with the blue food stream. So the stomach acid is just water falling in on top of the blue at the bottom of the screen. That allows the stomach to give you portion control with its small size, immediate shutdown of your appetite by getting intestine filled with food, and the food in the intestine meets up with the stomach acid so it can digest normally. That's why we keep your old stomach in there in a gastric bypass. So in a nutshell, the gastric bypass has the best weight loss, although this is dependent on the surgeon and the aftercare. I can't emphasize that enough. If you're having any sort of bariatric surgery, you need to commit to lifetime follow-up with your surgeon to keep the tool of that surgery working for you the way you want it to work for you. The medical problems go away faster and more often than the sleeve and the band, and it's a stronger operation than the band and the sleeve. It also has the best appetite suppression. So a lot of my patients who choose the gastric bypass choose it because they want the operation that has the best appetite suppression.